Hey, Dr. Vaish.
Face.
My name is Nicole Carpio. I'm one of the PGY3s at Mount Sinai. Thank you for talking to us today at FUS 2024. Do you mind just giving us a little background on who you are and what you do?
Sure. Thank you, Nicole, for the opportunity to speak with you today. So I have been in Florida for the last 13 years. I actually did my medical school in Chicago. That's where I'm born and raised.
Okay.
And then I left to go do my residency at Mayo, Arizona. And then after that, went back to the Twin Cities in Minneapolis to do my fellowship in actually neuromodulation. I was lucky enough to be at the right place at the right time and met my chairman at Cleveland Clinic in Florida. And they were looking for a female urologist, and I actually happened to fit the bill since I already had a Florida license. So I moved down with the family 13 years ago, and I've been part of Florida Urologics since 2014. So this has been really, it's a great small meeting. It's really great science, and it's really a lot of nice people. So that's how I got here. And I really enjoy my practice here, and I enjoy my partners, and I enjoy my colleagues.
That's awesome. That's great to hear. You gave an excellent talk today on sacral neuromodulation. What advice do you have to young, attendings or, that are starting their practice regarding sacral neuromodulation and how to build a
Sure.
good practice?
So I think that the important thing that whenever you start a practice anywhere is be very comfortable with who you are and what your techniques are. Don't let people talk you into things. And then second, I think people get overwhelmed when they start a practice because not everyone's been taught to meet, Mr. Smith or Mrs. Smith, and they walk in and they're a 60-year-old woman that has overactive bladder. Like, how do you start with offering them options? So the following, I think the overactive bladder care pathway is really a good thing to implement in your practice. And if you stick to that, you're going to do great because you're going to start with the appropriate therapies in order. So you're going to offer them non-invasive biofeedback medications, and then you'll move them along to third line because you're going to find that 50% of people are going to do really well with the non-surgical interventions. So we need to remember that even as surgeons, we're still urologists, and sometimes our practice is non-surgical management and surgical management.
Yeah, that's excellent. Thank you for that advice. During our panel discussion, we also sort of discussed Bulkamid. Do you do Bulkamid?
I do. I
Okay.
do Bulkamid. So Bulkamid was released February of 2020, which was actually at the height of COVID. So they came out with their indications actually at the SUFU meeting, and we were all very excited to get started. And about a month later, the world ended, right? So the world, it became closed to travel, closed to learning. So we had this amazing therapy that none of us could be trained on.
Yeah.
So luckily, about a year later, we were able to do kind of dry labs and wet labs in our facility.
Okay.
So we were able to be trained. And since then, so that was March of 2021, I have been doing Bulkamid. So I started really doing it just in the office, and I would do Bulkamid days. I would have 3 to 6 patients come in, and we would treat their SUI. Now I still do that in the office, but I also have started offering it to patients in the operating room because despite using a lot of local anesthetic, patients can still be really uncomfortable. So you want to make sure you're giving your patients a choice. But I love the results I'm getting for Bulkamid, and so I'm going to definitely continue to offer it to my patients.
That's interesting. So at my institution, we do it only in the operating room. I guess what are some difficulties that I know you said pain management, but how do you sort of manage that in the office?
So one of the things that they do in Europe is they use EMLA cream. So EMLA cream applied to the anterior vaginal wall, which patients can do at home. So I prescribe it for them before they leave. And then we reapply it when they come into the office. In addition, I offer my patients a Valium as well as a Percocet to do ahead of time. And you're going to laugh at me when you hear this because I actually started doing that when I went to a vasectomy clinic at Planned Parenthood. So the gentleman who taught me how to do vasectomies in the office was like, listen, you can either have patients that are really uncomfortable or you can give them some pre-treatment and they're going to be much more compliant and they're going to show up and they're going to go through their vasectomies. So I actually translated that to my in-office procedures for Bulkamid prior macroplastique and also for my Botox patients.
Okay.
So I do find that patients tolerate it. I mean, we do have some patients, like I have one lovely patient who goes vasovagal when you cath her. So we did in the operating room.
Of course.
But again, it's giving patients choices, but you have to be able to manage their pain in the office. And the other thing that you have to remember is that your nurse is in the room who's a patient advocate. And you want to make sure that the nurse is comfortable with what you're doing. You got to make sure the patient is comfortable. And by and large, I have found that my patients have done well in both situations. Yeah.
Excellent. And then now that you've given sort of patients the option to either do it in the office or in the operating room, have you found that more people are, tend to request to do it in the operating room?
I have actually found that. And what I've actually found is that patients are getting better outcomes. In the office, they tend to move and jiggle and move around. And then you get a little bit of bleeding, so you've got to flush that away. So you have to reposition. In the operating room, it's a lot smoother and it's fairly quick. I mean, it's less than 5 minutes to make all these cushions. And I have actually had a better success rate in terms of people are just drier. And I think that's because they're not as uncomfortable and wiggly.
Fair. And then how do you manage them with catheters after? Do you leave a catheter in?
I think it depends on, I usually try to leave them full, about 250 to 500 cc's in their bladder, and then I crudé them. If with the crudé I don't get anything, I might slide in a small catheter. I might slide in an 8 or a 10, generally, but I don't necessarily cath everybody. If I feel like I've gotten a really good treatment, I will, just to make sure that they're open. And by and large, sliding that 8 French afterwards has really helped prevent the retention rates.
And what are your retention rates?
Probably less than 2%.
Okay, excellent. Well, given that you're a female in urology, I think it would behoove me to ask you sort of any advice that you have for female residents in general, and then specifically also, I think sometimes we feel, we sort of have to do a fellowship to sort of, do the cases that we sort of want to do or see the patient populations that we want to see. So do you have any advice regarding any of that?
I will say you should do what you love, right? So when I originally went into this, I really thought I was going to do a lot of laparoscopic kidneys. And then after a while, when I was a resident, I just didn't enjoy those bigger cases as much, and I enjoyed the patient population in female. I did a fellowship because I wanted to be able to offer my patients appropriate treatment. And I didn't feel that I wasn't necessarily trained well for it. I just wanted to make sure I was the end-all be-all. Like, I know what the latest and greatest is for you. Now, if your latest and greatest is you want to treat bladder cancer, then by all means do a fellowship in bladder cancer. However, there are plenty of female urologists that go into general urology that are happy. Okay? So it is about being happy with your decision. And when you go to the OR, if you're going to the OR and doing a cystectomy versus doing a Bulkamid versus doing an InterStim, you have to be happy with what you're bringing those patients. And if you're a happy practitioner, you'll be a happy doctor, you'll be a happy mom, you'll be a happy sister, you'll be a happy everything. So think about that first. Do you have to do a fellowship? No, you don't. But you have to decide, what are you going to be able to offer your patients? And we had lost our female urologist for about 2 years, so I didn't feel like I got enough exposure, which is part of the reason I chose to do a fellowship.
Okay, thank you. And I know last year here at the FUS, you actually gave a talk on wellness. Any advice for residents nowadays on wellness? And
that talk on burnout was really near and dear to my heart. I think that COVID really shed a light on people and our interactions in the clinic, and how people perceive us and how we perceive them. So what I would tell you as a resident is one thing: it's a specific period of time. This is not your end-all be-all. There are days you're going to get into the hospital at 4 a.m. and you're going to leave at 10 p.m. and that is part of your training. It is a kindler and gentler training day. I mean, these days there's the work hour restrictions are real. You are going to see less surgical cases, which is why a lot of people are doing fellowships. But I think keeping focused on the fact that this is not a permanent way of life. Okay. And I wouldn't say I had a hard time, but by chief year, we were on call every other night and every other weekend. It was unsustainable, but it was a finite period in time. That's not what it's like as an attending, unless you choose that. You don't have to choose that. Let's also keep in mind that we are a surgical subspecialty where there'll be one of us for every 100,000 people coming. So our workload is going to be up to us to cut off. And that's the biggest thing with our burnout. Remember, there was a slide that said, this is your boundary. You have to set your boundaries.
And I think that's something that is very important for us to learn in residency, correct? Like learning to voice concerns and, talk to the people around you. And
well, and one of the other things that I said in that talk is one of the things that can de-stress you the most is having a drink with a friend, going for a walk with a friend, and spending time with colleagues who understand that same plight. The friends that you make during residency will be your friends for your entire life.
That's great advice. Thank you so much for talking with me. It's
Of course.
an honor being here with you.
Oh, well, thank you for that. I
Of course.
appreciate it.
Take care.